Somebody says, is the combination of ACE and ARBs the best choice?
So I'm going to let Louise deal with children, and then I will deal with adults. Or Pete can do. I'll deal with adults. Oh, and I need to unmute Louise. Sorry.
So we don't use ACE and ARBs together in children anymore. We would usually use one or the other. And usually we start with ACE inhibitors, and if they're not tolerated, then we would use an ARB, but we don't use them in combination anymore. And that's mainly because of trials where they suggested that patients might get raised potassium levels. Now, we don't commonly see that in children, and actually most paediatric nephrologists were quite comfortable using the two drugs together. But I think there's a general consensus now that we don't use them in children together. We tend to use one or the other. Children often don't always tolerate the full dose of the ACE or ARB anyway, because their blood pressures are usually okay, and we sometimes drop their blood pressure a little bit, that they start to feel dizzy or have fainting episodes. And so we can sometimes struggle even to use one of the medicines in the full dose, and that's another factor that comes into it. But generally, most of us don't use both of them anymore, although I suspect there may be some cases where patients are on both, but as a general rule, it's usually one or the other.
And that's the same in adult practice. We would use one or the other, although it's fair to say what we do in the UK is not mirrored necessarily in mainland Europe or in North America. So there are some parts of the world where they really do use both together, and that's standard practice. The reason we don't use them in adult practice is there were some studies of dual therapy where there looked like there could be a risk to the heart by using both. I'm not sure that data necessarily translates to adults with IgA nephropathy, because those studies included a lot of people who already had heart disease and diabetes. But the practice in the UK is not to use both together. But I know people in mainland Europe, North America, do often use them together. But it's just not something we do in the UK. And in Pete, in terms of transplantation, that's not something that we would be doing either, is it?
No, we would certainly never use them in combination in transplantation. No.
And I did actually see some of the comments. I think Louise mentioned high potassium levels, and this does become an issue with these types of drugs when your kidney function falls. And actually, we may well proactively stop the ACE inhibitor or the ARB once your kidney function falls below a certain level. And here we're talking about the teens or below 10, because we are running into problems with high potassiums. And certainly when we are sending our patients to Una and the other dietitians, one of the first things we're looking at is, are we giving the patients any treatments that might be raising their potassium? And so certainly in the low clearance clinics, so people with kidney function down to 15% or lower, we may proactively stop these drugs because we're worried that they could be causing high potassium levels, and that's quite common. So it's nothing to be worried about. It's really for your safety that we're stopping these drugs.